South America, Argentina, Córdoba. One of the most beautiful cultural and educational cities in the south of the world. Epicenter of the first university of the country, one of the oldest in the Americas. Knowledge, scientific progress, medical sciences, supported by last-generation technology, deeply committed to society and science. Right there, in an emblematic institution in the heart of the nation. A team of professionals with solid experience and outstanding expertise. A human group committed to the best care for children with congenital heart disease. Research, medical sciences. Argentina, south of the world. Hospital Privado Universitario de Córdoba. Since 1947. Ethics, knowledge, innovation.
Good morning.
Hey, Alejandro. It's Damien Kenny here. I'm up on the podium with Z, and we have our digital moderators, Dan Grunstein and Alex Javoy, and our panelists, Carlos Abal, Juku Wang, Mac Mabid, and Al Galindo. And we're very much looking forward to your cases. And happy birthday, 1947, your hospital, so you're 70 years old.
Thank you very much.
This year.
It's a real pleasure for us to be part of PICS every year. You know, this is a special event because it's the 20th anniversary, and we would like to thank Siad and all the course directors and co-directors for including us in the name of all the pediatric interventional cardiology in Argentina. We are very, very grateful to that because PICS has helped us to spread the knowledge and the innovation for the best care of the patient with congenital heart disease. We are working here, just many people. We have been doing this for a couple of years, and getting ready for PICS is a big event for us. So during the last 2 or 3 months we have been working, and I would like to thank and introduce our crew here today. The anesthetists, Mr. Cabana, Dr. Salzano, Dr. Priotto, they are the cardiac anesthetists helping us today. To my right hand side is Adolfo Ferrero, who is my partner.
Hello,
and working with me every day. Our fellow, Jonathan Miara, and our head nurse, Pablo Pogonza and Sonia Albano, and our techs, Osvaldo Narciso and Sabrina. And also a special thanks to Alejandro Contreras, who is our echocardiographer every year, and he has a great expertise in this. So, we will show for the syllabus. This is case number 1 for Córdoba, and so Adolfo will run through the slides so you get an impression of what we are going to do today here. Case 1 for Córdoba, please. The slides. Next. Next, please.
Well, this is our today's first case. It's about a 12-year-old girl who born with diagnosis of pulmonary atresia with intact ventricular septum and a small right ventricle. She suffered from fatigue and mild dyspnea in exertion and increased cyanosis. She was recently referred to our program for further care. Her weight is 50 kilograms and her blood pressure is 106/68 millimeters of mercury, and her peripheral saturation is 87%. She has a mild 2/6 systolic ejection murmur at the left upper sternal border with a single second sound. And her past medical history is at the age of 5 days. She had a left modified BT shunt at 18 months old. She had a bidirectional right gland anastomosis, and at the age of 9, she has an extracardiac 20 millimeter fenestrated Fontan-Kreuzer anastomosis. And during immediately post-operative period, she developed a right ischemic stroke with residual mild left hemiparesis. The next, please. She is on aspirin, 100 milligrams each day. Her pertinent tests, the EKG in sinus rhythm with a right atrial enlargement and right AICS deviation with a heart rate of 28 per minute and incomplete right bundle branch block. And the 24-hour Holter shows sinus rhythm with infrequent PVCs. And the 6 meters walk test, she walked 410 meters, and after that, her saturation dropped from 87 to 79. The chest X-ray shows a mild cardiac enlargement with elevated cardiac apex, and the TE echo shows a pulmonary atresia with intact ventricular septum with the status post extracardiac fenestrated Fontan-Kreuzer anastomosis without thrombus, and the left ventricular function is preserved, and there's no significant AV valve or aortic valve incompetence, and there is non-restrictive ASD. The next, please.
Next.
The chest X-ray, please. Yeah, well, this is the chest X-ray, and the next is the EKG. The next, please.
Next.
And this is the EKG, and the next we have the TE echo.
Next.
Here, the TE echo showing the 6 to 7 millimeter in the extracardiac Fontan-Kreuzer anastomosis, and then the CT reconstruction. Yeah, the cardiac CT reconstruction showing the bidirectional gland anastomosis and the mild LPA stenosis and the MPA pouch. Next, please. This is the cardiac catheterization, and here we have in the left side the bidirectional gland, and in the middle the Fontan tube, and in the right the LPA with the MPA pouch. Next, please. Well, the intended intervention is LPA stenosis and MPA pouch evaluation, cover stent implantation, and fenestration closure using either a PFM ASDR device or a PFM PFO device.
Okay, that's clear. Do you need any further clarification before we start discussing the case?
No, I think that's very clear. It's a nice presentation. Maybe you could show us some angiography and hemodynamics.
Hi Alejandro, Mark Ramed here. I have a question for you. On the picture of the gland, the IVC looks like it's directed more towards the LPA. Did you get an injection, excuse me, from the IVC to make sure that there is enough hepatic flow to the right, that you may have AVMs on the right?
Perfect. So we have done hemodynamics. We have done the diagnostic part of this study 1 month ago when we sent the picture to SIA, and we thought that this was a very good case for discussion. For the purpose of PICS, this is a very didactic case, so we will discuss here what we are going to do further. But next, please, next slide.
The last one. Because we actually did all the evaluation, and this is the way that we have been doing this during the last 10 years in Córdoba. Many centers for sure have different ways to do this, and we stick to a
protocol that actually we copy from Siatz and Bill Hilbrand paper in Circulation in July 1992 that they indicated how to evaluate this patient. You know that when you close the fenestration, there is a decrease in cardiac output, an increase in oxygen saturation and concentration. But the amount of decrease in cardiac output is approximately 23%, and the amount of increase in oxygen saturation is about 10 to 13%. So how the body reacts to that and how to compensate that. The systemic oxygen transfer of delivery also cannot compensate fully, so they drop a little bit, but the O2 extraction increase. So in this case, we measure pre and post closure of fenestration, mixed venous saturation sat that you see didn't change a lot, and the behavior of the MV sat is a little bit erratic in this patient. The aortic sat increased from 85 to 95. The cardiac output decreased from 2.12 to 1.79. That is a decrease in 15% change. The systemic O2 delivery or transport decreased by 5%, and you see that O2 extraction goes up from 0.37 to 0.39. The right atrium pressure didn't change dramatically, so that increases 1 millimeter of mercury, 12 to 13, and the systolic blood pressure also didn't change a lot. So we take into consideration all these calculations, and I would like to advise you to go to see that paper, but all the formulas are there, and we have to the fellows we teach how to do that with Excel, with all these calculations, and for us have been working very well in order to select patients for fenestration closure, the favorable patient versus the unfavorable patient. So we will start showing you the first angiography that we did this morning. So the marked pigtail catheter is in the innominate vein. You see there the innominate vein.
We don't see the angiograms yet.
Okay, so please.
The angio, please.
Angio, please.
Thank you.
You see there the marked pigtail in the innominate vein. You see there the vein coming down to the right gland, and then you see the right pulmonary artery that is nicely seen. There's no gradient anywhere there. And you see also the left pulmonary artery with something weird in the middle that you saw in the CT angio and also in the image that we sent before for the silver, that is the MPA there. And you see there the fenestration located in the extracardiac fenestrated Fontan-Kreuzer circulation. Next one, you don't see a lot of collaterals there. There is another image there in the extracardiac conduit that is a little bit bent, and there are no major stenosis there. The gradient or the pressures are exactly the same everywhere, but you will see the next one. This is a 30 oblique view, that the 30 left oblique view that you see the left pulmonary artery where the original MPA pouch is located. So with this in mind, we just did pressures there before and after fenestration closure, and there are no really gradient there. At the most 1 millimeter, but there's no gradient to tell you, but there is that pouch. So we are actually are not sure which strategy is the best for.
Well, let's
so
maybe Alejandro will ask people, just based on that angiogram, on the fact that there's very little gradient across that area, and you have Fontan pressures of, I think you said 12 to 13. Would anybody consider intervening on this with a balloon or a stent? Who would leave this alone? I think the majority of people say they'd leave it alone, but Dan Grunstein has a comment here.
Hey Alejandro, how are you? I would agree with going ahead and taking any narrowing out of the LPA at this point. I think when you did your test occlusion hemodynamics, there is a pretty significant drop in your cardiac output that may be due in part to any increased resistance in the pulmonary arterial tree. And I don't think in this setting in a Fontan that pullback gradient helps to determine whether or not there's significant stenosis, because it's low flow and you have the option to just push more blood into the RPA if it's significant. I think if you perceive that there's a significant narrowing there, and certainly on your CTs it looked like it, I can't tell on this angle as much, I wouldn't hesitate to go ahead and take that out of the picture, and it may help tolerate fenestration closure afterwards.
Jackie.
Hi, Alejandro, great job there. I wonder if you can measure the narrowing just proximal to the pouch and how that compares with the LPA prior to the takeoff of the left upper lobe. Because if that's not any smaller, placing the stent won't change your pressures or resistance at all.
Yeah. Okay, thanks, Jackie. Actually, we measure that. We can go back to show the measurements. Actually, we measure the approximately is 11.88 and distal is 10.37, and the waist is 7. So just take into consideration that this pouch is a potential risk for thrombus formation, and also this patient has had an ischemic stroke after the last surgery. So we are not sure if we leave this in the circuit, even if he has just 1 millimeter mercury of gradient, is the best for the patient. Maybe Siad, can you comment your opinion, please?
Yeah, I mean, you know, this is really a tricky issue here, what to do with that. The two measurements that you have there are very close to each other, so I personally, at this point, probably would not do anything for it. Close the fenestration. You can always come back and, you know, stent or do whatever you want with that. But at this point, it's very mild narrowing there that I don't know the value, whether it needs to be opened up or not.
Alejandro, maybe the other thing to consider is that in a marginal circumstance like this in a single ventricle who may ultimately go down the route of transplant, you put a big stent in there, it may impede decisions or options for this patient in the future when it's not very clear-cut.
Alejandro, this is Dan again. I think it may be the projection or it may be my memory, and either one it could be. But I thought in the imaging that you showed, the pre-catheterization imaging, that you had an angle that was a little more cranial than this. And I thought that area was a little bit more narrowed right at the bifurcation where the native RPA had originated. Having said that, and there is obviously post-processing issues where you can subtract out a little bit more on the CT or MRs, but I don't know if you have that image available still? Or if you could do another image of this with a little more cranial angulation.
Actually, that is an old image from 1 month ago. That position, we have this today, and actually, I'm not convinced. Can you pull the audience to see if they back me up to put a cover stent here?
We have another comment from Hoida.
So it really doesn't look very small, but one of the things that we've found helpful is to use a sizing balloon and inflate it at the LPA and just pull it back while it's inflated, and it contours the whole area, so you get a better idea for whether these are just little kinks or real stenoses. And the other thing too is that some of these patients can already have airway narrowing, and by stenting the branch PAs, you can further compromise their airway, which will actually cause them to have elevated CO2s, particularly when they're asleep, and long-term will cause problems. And so we tend to use a sizing balloon, and then we do a 3D rotation to look at the airway before we stent. So if you're just going to balloon it, that's fine, but if you're going to stent it, I think you need to be sure it needs to be done and that your airway is going to be okay.
Perfect. So just because we have to keep working, because we have many things to do, we actually cross a balloon there, and we cross a balloon when we did the initial study, and there was a waist in the balloon approximately at 7 millimeters. So with the history that she had an ischemic stroke, and this is a pouch that could potentially be the source of clots there, we moved forward and we actually decided to put the stent, a cover stent. So next one. So we just, the lengths, you saw there that the diameters were almost 12 approximately at 10.8 distally, and the length is approximately 31 millimeters, that the area that we would like to cover. So we decided we have here two options for cover stent. We chose the CP stent, AICS, 34 millimeters over a 12 millimeter balloon.
Okay, Alejandro, we just have a comment from Elkanen here.
I mean, it's fine to go ahead and stent it. It's an open issue, but I just think there's two things. First, the left upper lobe looks a little bit challenged, probably from the BT shunt. So in fact, the amount of left lung that's going to get a lot of blood here from this stent is not much. But the point of the stroke, I think, is more to do with the fenestration than the MPA pouch. The pouch that's been described that's problematic is when you haven't oversewed the pulmonary valve and you have a pouch which connects to the ventricle. Here, this pouch is going to cause a PE. It's not going to cause, I don't believe there's a clot that's going to come out of that, drop down the fontan and go across. So I personally wouldn't use a covered stent. I just use a regular stent. I wouldn't stent it because I think the left upper lobe is probably a little bit hypertensive and has small branches. And that's what I wanted to say. But I would close the ASD.
Elkanen, the other important issue I think that correlates with what you have to say is that the covered stent may have limited ability to dilate as she grows, whereas a bare metal stent might be easier to expand. I don't know if you would agree with that or not.
No, I mean, we have covered stents that go up to 22 millimeters. I don't see that as an issue. I just think less hardware. But it just doesn't make sense to me so much to put in a covered stent for the stroke reason, and I'd much more go for the ASD. Once the ASD is done, I'd repeat the 6-minute walk and all this type of stuff. And then if you still think that the stent is problematic, then if the stenosis is problematic, then I would just come back and stent it, maybe.
Okay, Alejandro, keep going.
I totally agree with Elkanen and the patient that have developed stroke is with the MPA pouch when you leave the leaflet open. I'm totally aware of that, but in this case, this is a pouch. This is the original MPA. So, next one, you see there how the stent was inflated. Next one. And next one is an angiogram. As you see, the stent is in place and the pouch has been excluded and is nicely seeing the diameter of the left pulmonary artery that we think that is in a proper position with no gradient to that. After that, we will go to the echo, please. We will evaluate. We have 15 minutes left, so there you see echo, please. Echo. You see there, guys, the transesophageal echo showing the fenestration. This is in the upper part of the extracardiac fenestrative fontan. It measures approximately between 6 and 7 millimeters by color. So what we did here, with a Berman balloon, we occluded that. You see there the image, how the balloon is positioned over the fenestration, and you see how it closed, and we did all the measurements. You see, next one, you see, next again. Angio, please now, next. You see there how the Berman balloon is inflated with a little bit of diluted contrast to see well the balloon, and for 10 minutes you just close the fenestration and evaluate again all the hemodynamics.
Alejandro, can you tell us just for the audience how you measure your pressure in the fontan circuit? Do you have a separate axis or do you put it up through a larger bore sheath? How do you measure simultaneous pressures?
Perfect. No, if you see here, can you just show it here? I have, please, camera. I have an arterial axis, camera. You have an arterial axis, and you have a first venous axis, and you have a second venous axis. So I do these procedures with two femoral venous axes. So, next one
Alejandro?
will be, how do you recommend to... Yeah.
So, Alex Javoy again. So one thing that we've monitored when we do these temporary occlusions, you can use a Berman angiographic with side holes that will measure the Fontan pressure, but also we've looked to see the SATs will certainly rise, but you did note a drop in cardiac output. What we've found useful is to follow lactate levels too with the temporary occlusion, because I think if you see a rise in lactate and drop in cardiac output, you wonder if cardiac output is dependent upon this fenestration because of pulmonary vascular resistance issues, that sort of thing. That was a pretty significant drop in SATs on the walk test.
Alex, how long do you wait to check, and what's considered a significant bump in the lactate? Both excellent questions. We have no data to answer either of those questions, but we always do at least a 10-15 minute wait. And I think almost any rise in lactate with a drop in cardiac output is a significant finding. And our choice has been to treat with pulmonary vasodilators long term, and then repeat the test occlusion, 2-3 years down the road.
The drop in the cardiac index, when he did the balloon occlusion, was about 15%, and the systemic oxygen transport was 5%. So I personally doubt very much that there will be any change in the lactate. But obviously, if you have a lab that can do it for you and stuff, I think it would be a good thing to look at a study, a few patients, and go from there. Because even if the lactate, let's say that increased by, I don't know, millimole or something, what are you going to make out of this?
Let me ask just a very general question. Given long-term problems with Fontans, with hepatic cirrhosis and protein-lutein enteropathy, et cetera, is there any group that is actually leaving these fenestrations open? This one may be a little bit larger because they were saying it's 6 to 7, but most fenestrations are about 3 or 4 millimeters. Is there anybody who's leaving it open as a prophylactic? Because this is very artificial to do this under general anesthesia laying down.
See, the problem, Al, with leaving them open is the small risk of stroke. It's small, but it is a risk there, and if you have your patient gets a stroke, it's a problem.
The other thing to add to that is that, we've looked, I think Jamil Abeloussen has looked at this in the adult population in the single ventricles, is that if you leave patients blue, cyanotic chronically, they do tend to it has an impact in remodeling their ventricle, and they tend to get high diastolic pressures, and we think Fontans fail because of pulmonary artery pressures, but if your diastolic or atrial pressures go up, you're equally as likely to fail. So I think, you're potentially
Alejandro, continue to work while we're discussing these things here. We have a question from Joachim. Continue working. Go ahead, Joachim.
Just one very stupid question. What's the altitude where that, because Chile has many patients living in high altitude, so if she was living in the high altitude, I would probably be more conservative in not closing it. But if she lives at sea level, of course, it's a clear indication of closing.
I think Córdoba sea level.
Sea level?
I think so.
And she lives in sea level?
Alejandro, where does she live?
Yeah, no, we are not at high altitude. Chile is much more. We are at sea level. So
okay,
we have
continue.
10 more minutes. So I would like to advance with this, saying how we are going to close this fenestration. We have made all the tests pre and post closure, and we are confident that this patient needs the fenestration closed. She will improve his exercise capacity, and also I think that the risk of developing a new stroke is going to be reduced. So during the last few years, we have been using many devices for closing fenestration, but during the last year, we have started using the PFM ASD-R device. We can talk about PFO device versus ASD device versus covered stem for closing fenestration, but I would like to close the fenestration first, and then if we have time to discuss all the other possibilities. So
that
you
sounds
see here
good.
What we chose today. We chose actually PFM ASD-R device. The smallest diameter that they measure is between 6 and 7 millimeters. So we are going to try to implant there an 8 millimeters ASD device. This is a device that is constituted by 2 discs. The left disc, make you this bigger, please. Bigger. Look, how you capture and then you recapture. This device has a locking wire distally crosses entirely the device, and then you see how it opens in a reverse reconfiguration way, and then the middle portion, and then the right atrial disc. The device is the release mechanism here is with a snare at the base of the right atrial disc, where the locking wire crosses the device. Distally, the locking wire is 0.04 inches and approximately 0.14. So this has the advantage that it's very flat in the septum or in the fenestration. It comes from 8 millimeters to 30 millimeters in 2 millimeters increment. We are talking about the middle portion, and the disc of this device that is 8 millimeters, the right and the left atrial disc that are equal in size is 16 millimeters. So what we are going to do now is just to charge the device inside the loader, and it comes as a unit. You see that you don't have to screw or to grab any portion of the device. Just comes as a unit. Everything has been flashed. Due to we were waiting, we just came back with the sheath that is a PFM. Go up. It's a PFM sheath that is braided at this 8 French. So it's a new sheath that they have developed for these devices. No pasa.
Ponemos el catéter en un segundo. Ahí es pasado.
Ahí. ¿Estamos, Ale?
Sí. Un poquito más si querés.
Okay, so we have been with a wire inside. So the sheath is 8 French and is already in the left atrium. You see there the echo, please. Echo. Echo. You see there how the fenestration is there, and the sheath, 8 French braided PFM sheath crosses the fenestration. Now Adolfo will flash the device and will.
Alejandro Makram here. Do you look at the pulmonary veins while you're putting the device to make sure you're not causing any obstruction to the left pulmonary veins?
Yes, in the echo, they show us the left pulmonary veins, and let's see here. 1 second, let's flash. Okay.
No, our surgeons, Macron, do the appendage. They fenestrate from the appendage, so it's more anterior. Usually the pulmonary veins, certainly in our center, are kind of a little bit more away from it. I don't know.
Can we see fluoro, please?
We are advancing the device, and there, Ale, we are inside the left atrium. So fluoro now. The right pulmonary. Right. So we discovered in this patient because it's
we don't
not
see
that
fluoro,
easy
Alejandro.
Fluoro, please. Fluoro, please. Fluoro, Angio. Perfect. So there is.
Can we get echo picture in picture, Alejandro?
Yeah. Echo down, please. Echo smaller, Angio bigger. Echo smaller. So sometimes it's not easy to portray the fenestration. So we found in this case that the right anterior oblique 25 degrees is the best way to see the disc. So we are inside the atrium, and we will start just there. You have the reverse reconfiguration of the disc, and we are coming back, and you see in the echo, on the echo, how the device is close to the fenestration. Coming down, you see that? Coming down, and
yep.
That is a typical Chinese hat reconfiguration. You see the 2 wings of the device, and you see the polyester membrane in the left atrium that is floating there. You mean that appearance we call the Chinese hat configuration, and you see how the device approaches the extracardiac fontan from the left side. You see, Ale, the echo is okay? So you see the echo also that is very close there. And now we are going to try to release the right atrial disc. That is released. Perfect. So when you are there, you just go with the sheath and try to reconfigure the right atrial disc. Okay? There. So you see how the disc in this situation does not reconform very quickly. You have to approach, once the device is in situ, you have to approach with the sheath, and once you are there, just with a counterclockwise rotation, you approximate the sheath to the right portion of the device that has a pine shape, and you just make it like look concave, and you see there that is the best position. So Ale, let's see the echo, the 3D echo. Make the echo bigger, please. So you see there the device in the circuit.
Are you doing 3D echo now?
Yeah.
We don't see the 3D echo, we see 2D.
Now Ale is obtaining the 3D echo pictures. So you see the device. There are two discs of the device crossing the fenestration. The two discs are right in the right position. Ale, you think that is okay? Great. Any comments? Any suggestion at this point?
It looks very nice. What are your oxygen saturations?
Great. And the saturations actually increase from 82, 83 that we started now are 92. Saturations increase. The same thing happened when we did the diagnostic part of the study. With fenestration closure, it increased by 10 points. So now we are happy with this position, Ale.
Ali, we have about 4 minutes.
Yeah. This is why I try to do this fast. So now we will release the device and do the last angio. The pressures are okay in the system, mean of 14. So Ali, we are okay there? Okay, so how, my hands now, please. Camera. So how are we going to release this? Just
could we get fluoro as well? So picture in picture with fluoro in your hands.
The fluoro, please. Fluoro big. Fluoro big.
Fluoro on the hands.
Fluoro and hand. And hand. Y las manos.
We have both.
So you see here the locking wire that exteriorizes the device. It is grabbed at the right portion of the device with a snare. So now the sheath is close by, and we start retrieving the locking wire, and that's done, and you just bring everything down and everything looks okay. So now, in order first not to be delayed, we will do a quick angiogram, so we will see if this is closed. Please connect the pump, please.
Baja demasiado la vaina. Quiere subirla un chiquito.
Aspirate for that. So now we are gonna do the last angiogram.
That's it.
While you're setting up for the angio, Alejandro, we have a question from Dr. Shalabi.
Only 2 comments. One of them, that right anterooblique and cranial 20 degree is better to show the perpendicular to the device, and lateral projection also I prefer. Other suggestion that I would like to flare the proximal part of the stents in fontan circulation because of the a little bit larger, and flow dynamics is very important in fontan circulation. There shouldn't be any space around the stent, especially in covered stents. So would you like to do flare with semi-compliant balance in this kind of patients, the proximal part of the stent, I mean.
Thank you.
Great. Thank you for the comment. So now we are ready to do the last angio. We are on time. So now, okay. So now this is in a very good position. You know that this device has a membrane all in the left-sided disc. So it takes approximately he's fully
Alejandro,
she's fully.
What's your ACT usually when you are doing these procedures? Where do you keep your ACT, and do you check it during the procedure?
Yeah, we keep the activating clotting factor approximately 200 seconds yet. The cardiac anesthetics is checking that. This is very common that the device has some leak in the middle portion very initially when you implant it, because you know that has just a membrane in the left side, and this is our experience when we close ASDs or the other type of defect with this device, that it takes approximately 24 to 72 hours to completely close. But this is a very good position, and the device sits nicely there. I don't know if you have any other comments.
This is a great case, Alejandro. Good demonstration for the LPS stent, which we don't know whether this is the right thing or not, but certainly the fenestration closure was a great case. Congratulations. We're going to stop right now and take a break for 15 minutes, and then come back in 15 minutes at 10:45 for the second session of live cases. Congratulations.